Read the question first. So, have you heard about this damage control surgery before? Don't worry about the options, but just have you heard about this damage control surgery? Yes, no?
No.
Yes. So basically, in damage control surgery, you do the first step in order to save the patient. Is that so, right?
Yes. So here, suppose we get a trauma patient. He is having multiple. Suppose he is having a bowel injury. Bowel perforation is there, and he is having a bleeding artery. We'll take him to the theater. We will just control the bleeding artery. That's all. And for the bowel, we'll just drain it. That's all. But we will not repair the bowel initially. You're getting my point? A patient is there with two things. One is a artery bleeding and bowel perforation, multiple bowel perforation. His BP and all is not stable. Okay. So what we do is we take him to the theater. We just close the artery, ligate the artery, and whatever bowel is there which is perforated, we just drain the abdomen and we'll come out. Once the BP is increased, after few days, after 3 or 4 days, we'll go again and we will do the remaining surgery. This is known as damage control surgery. Why is it necessary? I can finish off, right? Completely. Even we can do the bowel anastomosis and all at the same time. But why we are not doing? Just guess and tell. Guess and tell. It's okay.
So there's going to be inflammation from all over. The patient will not be able to tackle everything altogether.
Yeah, he will not be. That is partly right and partly wrong. See, the patient will not be able to tackle this. Surgery is a stress. He will not be able to take that stress. Okay. So there is a lethal triad. In any trauma patient, there will be bleeding, blood loss. So this will form a coagulopathy. Because of blood loss, all the clotting factors are used up. So it is known as coagulopathy. And he will have hypothermia because of fluid loss, hypothermia, and acidosis inside him. Okay, so remember CHA and I. Okay, in trauma, coagulopathy, hypothermia, acidosis. Okay, these are all the deadly lethal triad. So each factor will help on itself. That means, so coagulopathy will cause hypothermia, coagulopathy will cause acidosis. The same way, hypothermia will cause acidosis and hypothermia will cause coagulopathy. Acidosis will cause hypothermia, acidosis will cause coagulopathy. So these three are downward spiral. Okay, they go into a downward spiral and ultimately kill the patient. These three triad. Okay, so our aim is to stop this triad initially. So we introduce the concept of damage control surgery. So what is the most important thing? Any bleeding vessel, you have to ligate it and leave it. Control bleeding initially, and then resuscitate the patient. Don't focus much on surgery in the initial days. Okay, in the initial after trauma, what we have to focus is
Resuscitation.
Resuscitation. Yeah, you have to make the vitals normal. First of all, the BP should improve. His blood, any blood transfusion is there, you have to improve it. Acidosis, correct the acidosis. Give fluids to maintain the fluid balance. Okay, we should do all these type of things, and surgery is the second thing. Unless if there is a bleeding vessel, some bleeding vessel you have to go in first directly, and you have to stop the bleeding vessel. Okay. So there is a criteria laid down for this. Criteria for.
So what's the answer for that question?
Yeah, that's what. That is the see here. See here. So the criteria for damage control surgery, when you are going to do a damage control surgery, or when you are going to criteria for ETC is elective surgery. Okay. So damage control surgery, if there is hypothermia, if the patient is having hypothermia, do it fast. Acidosis, pH less than 7.2, yes. Serum lactate more, yes. Coagulopathy, PP is less. Transfusion approaching 15 units. Our injury severity score, we are going to discuss what is injury severity score. If these are there, just remember this, no need of this. These are normal parameters. And if these are there, you have to go for damage control surgery. So now you tell me the answer.
Serum lactate.
If serum lactate is more than 5, it is a bad prognosis sign. Okay. Hypothermia, yes. Acidosis, yes. Transfusion approaching 15 units, yes. Serum lactate is less, it is good only. For this, no need to go for a damage control surgery. Clear?
Yes, sir.
Others also, are you following? Yes, no?
Yes, sir.
What is the deadly triad?
Coagulopathy, hypothermia, and acidosis.
Okay. So only 2 points we discussed in trauma till now. One is what is deadly triad? Coagulopathy, hypothermia, acidosis. And what is damage control surgery? Don't need to go into these details of, if you remember, it's okay, well and good. But if you don't remember also, it's okay. But just remember those 3 points. Okay. So in trauma, we have the golden hour. The first 1 hour is known as the golden hour. The first 10 minutes are known as the platinum minutes. Okay. First 1 hour and first 10 minutes. And what is triage and where it is used? What is it and where it is used?
Used in emergencies and any patient who comes with a high risk patients, especially with the bleeding and so on, they are the ones go for triage.
Yeah, emergency
to categorize
partly
people.
Correct. Emergency is partly correct, but there is something else.
To categorize the severity.
Yeah, to categorize that, triage means to sort out. To sort out. Okay. So we categorize people, and this is used only in cases of mass casualties. Okay. Suppose a single patient comes to the casualty, there is no need to triage him. It is only in mass casualty. Suppose a bus accident is there, so you are expected to at least have 40 patients with you. So then the triaging comes. Okay. Yes, no?
Yes, sir.
Okay. So this triage is to give colors to the color coding, just color coding. So which is urgent? Red is urgent. Yellow is okay, like they are ambulatory. It is not so urgent. Green are normal people, they can be discharged. There are no need for any admission. And black is dead people. Just we'll mark it. We'll just flag the patient so that these patients require maximum attention, because the initial 1 hour is very important for them. These patients have maximum thing. So what are those? Airway obstruction. Again, no need to remember all this. Airway obstruction, tracheobronchial injury, pneumothorax, circulatory arrest, hemothorax, cardiac tamponade. These are some conditions which are
Red.
red. Yeah, which are what is the problem?
Very severe. They need immediate attention.
Yeah, life-threatening conditions. So they need immediate attention. And remember these so that if anything else, fracture. The fracture is not an emergency, isn't it? The patient will have pain, that's all. Okay. You will give some painkillers and you ask them to wait. After that, you can do that. Moderate hand injury. Moderate hand injury also is a yellow sign. Okay. And green, minor bruises or lacerations, small cut wounds are there. It is a very minor. Okay. And moribund patient. Some patients, there is like, they will be almost in the terminal stages. So no point in resuscitating them and wasting time. Okay. So we'll give black moribund patients. Okay. So this is the triage. So now tell me what is regarding color coding in triage. Which of the following mechanisms of injuries is not classified under category red?
Fly and chest.
Yes. Hemothorax is there. It's an emergency. Bleeding in the thorax. Pneumothorax, gas in the thorax. Flail chest is not there. Earlier it used to be there, but then you removed it. What is flail chest? I'll show you. And survey of a trauma patient. This is the most important, not for exam point of view, but just a trauma patient comes to you. Is survey. What is survey?
The head to toe examination.
Yeah. Survey is nothing but examination, proper survey. You should do a proper survey to the patient. Okay. So primary survey, secondary survey, and tertiary survey. Primary survey, it is ABCDE. We'll discuss what is primary survey. Secondary survey is your head to toe examination. You have to examine from top to bottom. Okay. So that any missed injuries are there, you have to see. And tertiary survey, if you don't do secondary survey properly, properly because the patient is intubated or not, then you will do a tertiary survey. Okay, got it? Primary, secondary, tertiary, got it?
Yes, sir.
Primary is the first time A, B, C, D, E, airway, breathing, circulation,
Airway,
visibility,
breathing,
and exposure.
exposure.
That is the primary survey. Secondary survey is head to toe examination, head to toe, everything. If in some cases you will not be able to do secondary survey because the patient is intubated, then you will do a tertiary survey. Once the patient is extubated, then you will do a tertiary survey. Okay.
Okay, sir.
So advanced trauma life support, that is A, B, C, D, E, and this C is control of bleeding vessel, airway, breathing, circulation, disability limitation, exposure. So before we go on to that, you should tell me quickly how we will check the airway of a patient.
Assess the ability to speak.
Keep our
Alarmness,
Sorry,
alarmness, breathing.
alertness, breathing. Okay. If the patient is talking, 100% sure that airway is intact. Otherwise, the patient cannot talk, right? So if the patient is talking, that is the one. If airway is not, if the patient is not talking, that means the airway is compromised. So what you will do? You will put a, what you will do immediately?
Intubate.
Intubate
Yeah,
the
you have to
patient.
intubate the patient. Intubation with endotracheal tube. And then, if suppose intubation is not there, you are in a mid of mass casualty, there are no laryngoscopes, which will be common, right? So what you will do then? Do a tracheostomy. Okay, just open it here. Tracheostomy or a needle, put a needle here. Okay, so trachothyroidotomy. This is about airway. Yes, no?
Yes,
Okay.
so
if the patient
something
is,
like they do in good doctor thing. Is it the same like cricothyroid? I mean tracheostomy, right?
sorry?
The airport scene in which there is airway obstruction and they'll use a straw to poke.
Yeah, it's all, it is same. Yeah.
Okay, sir.
That's more of a needle cricothyroidectomy.
Yeah, it is a
That's
needle.
an
It's not a
emergency
tracheostomy. It is a needle. It is an emergency procedure. If we just with the help of a sharp object, we can just puncture it. Okay, just puncture here. 2 finger blades above the suprasternal. If you just puncture, we will go into the trachea. That is a very crude technique actually. Okay, and then airway is okay. How to assess breathing?
Chest movements
Yeah.
and by percussion and auscultation as well.
Right.
By percussion and auscultation.
Yeah, percussion and auscultation. Yes. So, others also, please. Are you following?
Inspiration,
B,
percussion,
sir?
and auscultation.
Sorry.
B, please. B. How
Sorry, I'm
to
not
assess
able to hear.
breathing? How to assess breathing? So once again, please.
This one. Previous slide.
Yes, sir. No, this one.
Yeah. So how to assess breathing of the patient? Airway you have assessed. If the patient is talking, he is fine. If the patient is alert, he is fine. If he is not alert, he is not talking. That means that there is some airway compromise. You have to put a tube or you have to do a tracheostomy. That is done. Now coming to the second aspect of ATLS, that is second aspect of primary survey. So here
the
you will
screen
have to
is
assess the
not
breathing.
visible. The screen is not visible, sir.
Okay. Now?
Yes, sir. Visible.
Okay. So second, breathing. How to assess breathing is by inspection, palpation, percussion, and auscultation. Inspection. Just see whether the chest is moving or not. Okay. palpation, percussion, okay, we will not do an emergency. Again, we will auscultate, just auscultate whether both the air entry is there or not. If it is there, it is equal on both the sides or not. Okay. This is about
Okay,
breathing.
sir.
Is it okay?
Yes, sir.
Then circulation. You have to make sure that the patient is how is the BP and all. By checking the BP, you will know how is the circulation, and you will do a venous cut down. Or if you put a line, it's okay. If you are not able to put a line, you will do a venous cut down. Or in children, you will directly put it in the bone. Or in other cases, you will just put a central line into the IJV. Okay.
So yes, sir.
So this is circulation. And disability. To know the disability, why is it moving? To know the disability, we have a score.
Sir, why we have to do venous cutout?
If suppose you are not able to secure a line, if you are not able to secure a normal line, we have to do a venous cut down and we have to secure the line, isn't it? Yes,
sir.
yeah. Okay. So see here,
Glasgow
to assess the
coma scale.
sorry.
Glasgow coma scale.
Yeah, to assess the disability, we have to know the Glasgow coma scale. Glasgow coma scale is having 3 components in it. EVM. E is eye opening. V is verbal. How is the speech? M is motor. Okay. EVM. These are the 3 things. These are 3 findings which we will see. Eye opening is there or not. Verbal. How is he speaking? And motor. How is his motor response? Okay. So with these 3, we can tell whether the GCS is there or not. What is the minimum score of GCS? 0, 1, 2, 3. What is the minimum GCS?
3.
3.
Okay, just remember there is no 0. It is always 3 because each has single point at least. So 3. Maximum score is
15.
15. Yeah, this is very important. Okay, so the question will come. A patient we presented with the RTA to the casualty. He has spontaneous eye opening. He is confused speech and he is obeying commands. So what is the score? Like that, the question will be framed like that. Okay. So you need to know in detail about each group. Okay. You have seen such questions before?
Yes.
Yeah.
Yes, sir.
Yeah. So you have to somehow mug it up, or somehow you devise your own mnemonics, or somehow to know what is those eye opening, what is there, verbal response, what is there, motor response, what is there. So for EVM, eye opening has 4 points, verbal response has 5 points, motor has 6 points. So 4, 5, 6. So it is almost 50. It is around 15. So least score is
3.
maximum score is
15.
50. So if the patient is opening eye spontaneously, 4. If he is opening to speech, it is 3. If he is opening to pain, it is 2. If he is not opening, it is 1. Same way, verbal response, if he is oriented, 5. If he is confused, 4. If he is inappropriate, it is 3. If he is incomprehensible, it is 2. If he is none, no speech at all, it is 1. Motor response, if the patient is obeying commands, it is 6. If he is localizing the command, he is 5. If he is withdrawing, at least you are pinching him, you are withdrawing, it is 4. If he is flexing, it is 3. If he is extending, it is 2. If there is no response, it is 1. Okay? Yes, no?
Yes, sir.
Okay, so now tell me, a patient is in deep coma. So what is the GCS of that patient?
3.
Okay. It is 3.
or-
Deep coma patient will have a Glasgow coma scale of 3. Okay. So I used to do some mnemonics and all, but finally, once you get into practice, you will just know these things. Okay. But for exam purpose, prepare some mnemonic. Okay. So how do you remember is no pain, speech open. It is no is 0, no is 1, pain is 2, speech is 3, and open. Eyes are open. Normally it is 4. No pain, speech open. Okay. And then I remember it as voice. What is voice? V is if the patient is vocal. Based on the voice, if you are telling something and if he is listening to it, if he is oriented, it is 5. If he is confused, it is 4. Okay. If he is inappropriate, we call it as inappropriate, it is 3. If he is incomprehensible, it is 2. If there is nothing at all, it is 1. Is it clear? GCS is clear?
Yes, sir.
Others also?
Yeah, it's
So,
fine.
what's for nephro, sir?
No, this is just for me to remember. I used to write like this: none, extending, flexion, withdraw, localize, and obey. This is just a code. That's all. You can devise your own code actually. Okay. But this, I want you all to remember these 15 points. Okay, because it is a time-saving question also. So they will give, if so and so patient came with eye opening of this much, verbal response of this much, and motor response of this much. So what is the score for that? Like that they'll ask you. Okay. So for I remember it like this:
Okay,
flow. And for voice, just if you ask the patient, if he's oriented, 5. If he is not oriented, he's confused, it is 4. Inappropriate is 3. Incomprehensible is 2, and none is 1. Okay. I'm wasting most of the time here so that this slide is the most
Yes, sir. No problem.
drama. Okay. Okay.
Okay, sir.
So what they are doing here is log rolling. We call it as log rolling. See the picture, it is taken from Bailey directly. So this is the log rolling. What is the purpose of this log rolling?
To check for any trauma or bleeding.
Bleeding? Where?
To check check the back of the patient. To be
Yeah, to check the back of the patient. Okay. What is secondary survey? It is head to toe examination. Okay. We always check in the front, but there may be some spinal injury or there may be some penetrating injury in the back. So you have to shift the patient. So this shifting means not like just turning the patient off. There is a principle for that, and that is known as log rolling. As you roll a log, it should be turned by at least 2 or 3 people so that every part will be turned back. So there will be no flexion or there will be no abnormal flexion somewhere. Okay. So you should just turn the patient to the other side. So this is known as log rolling. Okay. And here see this. What is this? This is also from Bailey. What is this?
Head and neck support.
It's a fixation of the head so that they don't move the cervical spine.
They don't move the cervical vertebra. Cervical vertebra are the most, once the patient is not under his control, so the patient will have, if there is some deformity, some flexion, abnormal extension there, the patient will end up in paraplegia. So you have to first of all put a cervical collar. Okay, it is known as Minerva cervical collar. Okay, to fix the head and the cervical bone. So now, can anybody tell me what is this? What is revised trauma score known as? There is a score for everything. Okay, so GCS is a score, isn't it? So there is score for everything. What is this revised trauma score? Anybody heard about it before? Not heard?
No, sir.
Okay, so just see here. These are the 4 scores. 1, 2, 3. This is orthopedics. This is orthopedic score. The people will tell you. But from my point of view, GCS, What is the points for eye opening? How many points are there for eye opening?
4,
For motor response?
6,
6,
For verbal response, it is
5.
5.
5.
And for revised trauma score, there is a score called revised trauma score. It is random blood glucose, RBG. R is respiratory rate, B is BP, G is GCS. Okay? Yes, no?
Yes, sir.
So these three grouped is known as revised trauma score. Mangled extremity score is for orthopedics, and SIRS. SIRS is in sepsis. What is SIRS? It is systemic inflammatory response syndrome. It has 4 components again: heart rate, WBC count, respiratory rate, and temperature. Okay?
Oh, again, what is SIRS that you mentioned?
Systemic inflammatory response syndrome.
RBG, sir.
RBG is respiratory rate. R for respiratory rate, B for BP, blood pressure, and G for Glasgow Coma score. These three will be called as revised trauma score, RTS, revised trauma score. Okay, just an example, just to a mnemonic to remember those 3 things. Okay?
Okay.
Yes. What is child pug score? Child pug score.
For liver,
Yeah, for liver. What are the 5 things I told you? 5 parameters. What are the 5 parameters? A for?
A, B, C, D, E,
Yeah, A, B, C, D, E. A for?
albumin,
Good. B for?
bilirubin,
Bilirubin. Good. C for?
ascites,
Ascites. Good.
E,
D for?
encephalopathy, T
E for
for
encephalopathy. D for? INR. Very good. Okay. In the same way, so what is the answer for this? RTS includes? Option?
Option A is GCS, BP, and
GCS, BP,
respiratory.
and respiratory.
A blunt trauma, and one is a penetrating trauma. So what is blunt trauma? What is penetrating trauma? It depends upon what?
Penetrating trauma, liver.
Sorry?
Penetrating trauma, liver.
Yeah. What is the difference between blunt and penetrating trauma?
Blunt mean it's like a wood or something like that. Maybe
check, check.
Penetrating is when the organ is being, like for example, a stab wound. It is penetrates
Punctured by
that
a
organ.
foreign body.
Yeah, it all depends upon the nature of the object with which the force has been applied. Okay, so if it is a penetrating wound, there is it pierces something and it enters into the abdomen. It enters into the peritoneum. That is a penetrating wound. Okay, most of the times there are gunshot wounds and stab wounds. These are the 2 examples for that: gunshot wound and stab wounds. They are penetrating wounds. Whereas fall from height, vehicular accidents where the abdomen is not opened, okay, and sports injuries, these all come under blunt injuries. Okay, there is no penetration inside. Okay, so now coming to the most common organ injured. What is the most common organ injured in blunt injury? In penetrating injury?
The spleen.
Blunt injury, it is the spleen. Penetrating?
Penetrating is liver.
Penetrating is the liver. Okay, and seat belt injury? Seat belt. What is this called?
Mesentery.
Sorry?
Mesentery.
Yeah, mesenteric injury. Seat belt will cause mesenteric injury. And in children, liver injury. Liver is the most common organ injured. Liver. Okay. So blunt is spleen, penetrating is liver, seat belt is mesentery, and in children it is the liver. Okay. So how to investigate this patient? How to investigate a blunt trauma patient? So this is wrong here actually. So see, a blunt trauma patient comes to your casualty. So whether he is stable or unstable, everything depends upon that. What do I mean by stable and unstable?
Hemodynamically stable.
Yeah, hemodynamically it is stable or not. Vitals are stable or not. Vitals, the 4 vitals. Whether what is his pulse rate, is having any tachy or bradycardia, hypotension or hypertension, respiratory rate and temperature. If he is vitally stable, then we have 2 things. If the stable patient, first investigation is fast. It is known as fast. It is just an ultrasound. It is known as fast investigation. I'll tell you what is it. It is fast. He is stable. So you can have a detailed examination by using a CT scan. So stable patient, see the question properly. Stable patient, hemodynamically stable patient. First investigation is fast. Investigation of choice is CT, CECT. But for an unstable patient, the first investigation is fast and the investigation of choice also is fast. Fast is nothing but it is an ultrasound. I'll show you the images also. So why is it so? Why we are not doing CECT in a case of unstable patient?
Because it's the time which matters over there.
Yeah. So fast is ultrasound. As day before yesterday I told you, ultrasound is easily available. It is a bedside investigation. Whereas CECT we have to shift the patient, and while shifting or anywhere else there may be any hemodynamical instability. So just remember, a stable patient, first investigation is fast, an ultrasound. Investigation of choice is CECT. But for an unstable patient, first investigation is fast and investigation of choice is also fast. Here it is wrongly printed. Investigation of choice is also fast. So what is fast? It is an ultrasound. Okay. Normal ultrasound, we concentrate on so many other areas, but in fast we are focused. We are focused and we will be assessing only few areas in the abdomen, so that where there is any bleeding or collection is there or not, we are interested only in that. We are not interested whether the patient is having gallstones, whether the patient is having renal stones, isn't it? In an emergency. Yes, no?
sir.
Yeah. So this is just focused assessment with sonogram in trauma. So this is wrong. This is not focused abdominal sonogram in trauma. This is focused assessment with sonogram in trauma. This is the right answer. Okay. So don't get confused. Just see, it is focused assessment. It is not only abdominal. We will do the pericardium also. I'll show you. So it is focused assessment with sonogram in trauma. Okay. So see here, a patient met with RTA and underwent the following investigation. Areas screened are all except. See this picture. This is how we screen the various areas of the abdomen. Okay. Before we tell, just see this. These are the 4 areas. Normal 4 areas are the right upper quadrant, left upper quadrant, umbilical region, and the hypogastric region. Okay, and we have a thing called extended fast. Nowadays we are doing this extended fast. It is 4+2. Okay, we are seeing even the right chest and the left chest. What do we look for in right chest and left chest? Anybody?
Any injury to your lungs is what you're
Collection,
Fusion.
Yeah, collection,
effusion.
but effusions. Yeah, any pericardial effusion, pleural effusion. Okay, so this is an extended fast. So normally, so this is E fast. E fast is 4+2. Normal regions plus chest, 2 regions in the chest. Okay. So the minimum fluid required for fast, it is around 100 cc. If 100 cc fluid is there inside, fast can be useful. Okay. Yes, no?
Can you repeat once more, sir?
Yeah. Fast is an ultrasound. It is nothing but it is not no great investigation. It is just an ultrasound which is done in the initial period of trauma. Okay, so we are focused only on 4 areas in the abdomen. One is the right upper quadrant, the other is the left upper quadrant, one is in the epigastrium, and the other is in the suprapubic region. So see, left upper quadrant here, they are focusing. Right upper quadrant, subxiphoid. This is just below. This is in the epigastrium and suprapubic. Okay. So these are the 4 areas which we will be focusing. This is fast. And E-fast, it is extended fast. Nowadays we are doing E-fast to look in the chest also. So these 4 areas plus right side chest and left side chest. So 4 plus 2, we will access the 6 areas. And minimum fluid required is 100 ml. If 100 ml is there, then this fast will detect that fluid is present inside. Okay?
Yes, sir.
So now you
Okay,
have to
so
answer.
can we go back to that question?
Yeah, this is the answer for you.
Sir, wait, what is
If you
meant by
tell
4
us-
plus 2?
4 plus 2 is normally 4 areas in the abdomen plus 2 areas in the chest.
Okay, sir. Okay.
So just answer this question.
Left hypochondrium.
Left hypochondrium we have to see, right? For splenic injury, this is left upper quadrant we'll see.
Is it
Pelvis?
Pelvis.
Yeah. So pelvis, we are not seeing. We just see the hypogastrium. Okay. So no need to go into the pelvis and look for any correction. Just see the hypogastrium, suprapubic region. It's enough. Okay. Then coming to the penetrating trauma. I told you there is. What are the 2 mechanisms with which penetrating wounds shall happen?
Gunshot and stab.
Gunshot wound and stab wound. Okay. So in penetrating trauma also there are again 2 subcategories. Like one which is superficial to the peritoneum and one which is deep to the peritoneum. Okay. So if the peritoneum is not breached, if it is superficial to the peritoneum, then no need to explore the abdomen. If it is breaching the peritoneum, it is going deep to the peritoneum, then we have to open the abdomen and explore the abdomen. Is it right? Is it clear?
Yes.
So it is whether it is superficial to the peritoneum or deep to the peritoneum. If it is just superficial to the peritoneum, just open the wound and just close the wound. That will be enough. If it is deep to the peritoneum, you have to explore the abdomen. This is the point which is required. And what is this DPL? Anybody? We are not doing nowadays, but earlier days this used to be done. What is this DPL?
It's diagnostic peritoneal lavage.
Diagnostic peritoneal lavage. Okay. It is nothing but we'll just put a needle in the umbilical region and just aspirate the contents. Whether there is any food present, whether there is any bile present, whether there is any RBCs present in it. If anything is present, then it is an indication for laparotomy. Earlier days they used to do it. Nowadays we are not doing this diagnostic peritoneal lavage. Okay. Clear?
Yes, sir.
Okay. Splenic injury. Now, individual injuries we are discussing about. Each injury we will discuss. Splenic injury. So, in spleen, heard about this sign, Kerr sign?
Yes, sir.
So what is this?
Pain to the left shoulder in splenic rupture.
Very good. Pain to the left shoulder. Whenever splenic injury is there, there will be pain to the left shoulder. Okay. Right shoulder pain. Today morning we discussed. Where is that seen in? Right tip shoulder pain. In which surgery?
Cholecystectomy.
Yeah. In any laparoscopic surgery, it is not due to cholecystectomy. In any laparoscopic surgery, because of the pneumoperitoneum, the patient will experience right shoulder tip pain. And left shoulder tip pain is Kerr sign, that is seen in splenic injury. Okay. And now another concept of abdominal compartment syndrome. Abdominal compartment syndrome. Heard about it previously?
Yes, sir.
Yeah, so tell me basically what some basic points. Just this is a revision like thing. Okay, just tell me what are the basic points.
Increased intra-abdominal pressure.
Okay. It will lead to what will happen if we increased intra-abdominal pressure is there? What will happen?
It's compression of abdomen.
Yeah. And why is it happening?
It is greater than 20 millimeter Hg.
Yeah, that's okay. But why this is happening? Why actually abdominal compartment syndrome is happening?
Severe injury.
Okay. See, there are mainly three reasons for abdominal compartment syndrome. Remember 3 reasons. One is surgical closure. Surgical closure. So we operate on, suppose morning we have seen a patient is undergoing Whipple surgery. Okay. So we have removed and we have anastomosed. And again, if the closure is okay, abdominal closure is okay, it's okay. Otherwise, sometimes what will happen is there will be very tight closure of the abdomen. So then the intra-abdominal pressures are bound to increase. Tight closure of the abdomen, iatrogenic, one. And sometimes when we give a lot of fluid resuscitation, there will be excessive third space losses when we give a lot of fluids. Okay, so fluid changes. Then also there can be rise intra-abdominal pressure if third space losses are there. Okay, and finally, and the least common, it is any trauma. A trauma can cause abdominal compartment syndrome. Okay, so these are the 3 reasons, mainly by post-surgical closure, fluid imbalances, and trauma. So what will happen if there is raised intra-abdominal pressure? So there will be pressure on the IVC. The IVC will be compressed. So what will happen if IVC is compressed? You have to tell me. If IVC is compressed because of intra-abdominal pressure, what is going to happen? These are the MCQs.
Peripheral blood flow will be to the heart also.
Yeah,
Blood flow is altered.
Venous return will decrease. So the patient will have hypotension. That is point number 1. Compression on the IVC. The abdominal compartment syndrome will cause hypotension. How hypotension? IVC is compressed, so the venous return is decreased. So the blood from the heart will be decreased. So hypotension. And there will be compression on the renal artery. So what will this lead to? This urine output. Okay. Oliguria. Yes. Okay. Very good. And then the compression on diaphragm. There will be compression on both the diaphragm. On the diaphragm. So what will happen?
Inspirational pressure.
Yeah. So there will be respiratory difficulties. Okay. So these are the 3 things. Hypotension will be there. Oliguria will be there. Respiratory difficulties will be there. Okay. So what is this? This patient had an abdominal surgery and he had raised abdominal pressure. Pressures have been rising. So the abdomen has been opened and this is a Bogota bag. This is picked up from Bailey. So important for you. It is maybe asked as an image based question. This is a Bogota bag. So we will just open the abdomen and we will keep the bag there so that the abdominal pressure will gradually decrease. Once decreased, after 3 to 6 weeks of time, we will just close the abdomen again. Okay, so it is an emergency tidying procedure. So just open the abdomen and connect it to the Bogota bag. Okay? Clear?
Yes.
And normally the pressures are 12 to 15, between 12 to 15 millimeters of mercury normally. So there are grades 1, 2, 3, 4. 4 grades are there. Above 15 to 18, 18 to 21, 21 to 25, and more than 25. Okay, 15 to 18, 18 to 21, 21 to 25, more than 25. Depending upon the grades. No need to remember this, but just remember normal intra-abdominal pressure between 12 to 15. So, see this, which of the following statements is true regarding abdominal compartment syndrome?
B.
Just try to answer. Is the first one right? Sorry, is the C, the intra-abdominal pressure?
No.
Grade 1 ACS. It is wrong. Yes. Definitive surgery is immediately done, followed by closure of abdomen. Yes, no?
Yes.
No, we have just put a bag, it isn't it?
No.
After 3 to 6 weeks, if the severe pressure should return to the normal, then only we can operate. And see the first two.
Diagnosis can be reliably made by physical examination.
Diagnosis can be reliably made by physical examination. Yes, no?
No.
No.
I think A is correct.
Yeah, A is correct. There is reduction in visceral pressure and increase in intracranial pressure. But diagnosis cannot be made by physical examination. Okay. So there are special manometers which will be connected in, which will be put in the bladder, in the patient's bladder, so that we know the abdominal pressure. We indirectly measure the abdominal pressure. But physical examination, we can't tell whether there is intra-abdominal hypertension or yes, or no. Okay.